Good morning. Welcome to today's Recovery Summit presentation, Beyond Labels, Tackling Stigma Surrounding Substance Use. This webinar is part of a series hosted annually by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded on the CMH YouTube channel for future reference. Please feel free to use the chat box for all questions or comments. Our presenter will be answering questions as time allows. Continuing education credits are offered for today's presentation. If you are requesting professional credits, you must remain on the webinar the entire time and complete the survey at the end of the presentation to receive credit. Our presenter today is Carlos Rivera. Carlos is a community education coordinator at Face Addiction Now, formerly Families Against Narcotics. Welcome, Carlos.
Thank you. All right. Are we ready for me to get going?
Yep, you're good.
Okay. Good morning, everybody. My name is Carlos Rivera. I'm a community education coordinator with Face Addiction Now, formerly known as Families Against Narcotics. I know you guys are expecting Maddie Tortomasi this morning, but unfortunately, I'll be filling in. So just be patient with me as we go through this presentation. We are going to do our Face Addiction Now Substance Use 101 education, which includes stigma reduction. I will be asking the moderator for questions as I go along. So if you guys do have any questions, please feel free to share them in the chat and she will bring them to me. Okay, can everybody see this okay?
Yeah, we can
Good.
see it.
Good. Okay, so Face Addiction Now. It's our mission to be compassionate when assisting individuals and their families who've been affected by substance use disorder. We do this by offering community and evidence-based services to individuals and families who are affected by disease. All of FAN's programming is free, which helps individuals who are affected by addiction. We do have chapters throughout the state of Michigan, in the Upper Peninsula and in Lower Peninsula. We are constantly expanding and developing new chapters throughout the state. So our services are provided statewide. So why do people use drugs? People typically use drugs to fill a need. Sometimes that need might be to fit in. It could be to address pain. It could be to self-medicate for a mental illness. Things of that sort, but typically the reason somebody starts using drugs is to meet a need. Unfortunately, though, substance use can become a substance use disorder. That is a treatable chronic medical disease. It involves complex interactions among the brain circuits and can be impacted or affected by their genetics, their environment, or their life experiences. And this can often cause a person to lose control of their substance use. So substance use becomes really a substance use disorder when the changes in the brain really impact the person's ability to control that use and has an effect on their everyday life. Substance use disorder can be broken down into these specific disorders, which really just have to do with the drug of choice. So if somebody uses alcohol, we could call it an alcohol use disorder rather than a substance use disorder, and that could vary from drug to drug. So why is SUD a disease? It's a chronic medical condition, which means we can't treat it. This medical condition, we can't cure it, can really have an impact on that person's life for the rest of their life. Because we cannot cure it, but that doesn't mean we can't treat it. Substance use disorder resides in the brain. Okay, that's the major organ that it really has the most impact on. It has physical symptoms like cravings and withdrawals, but it is responsive to treatment. That treatment might not look the same for everybody, though. First of all, we have multiple pathways. Now, so one person might treat it with medicated assisted treatment, while another person works, a program, and another person is using clinical treatment. But really, when we talk about multiple pathways, we should be using a combination of different pathways to work a program that addresses that individual. So that individual can't plug and play their sponsor who's been in recovery for 10 years now and clean the whole time, plug and play their recovery plan into their life, because that's not going to affect them. Substance use is so affected by that person's history, their trauma, their experiences. Their recovery plan really needs to address these things. And then lastly, if we don't address substance use disorder, it can very well be fatal. This could be a drunk driving accident, or it could be cirrhosis of the liver when we're using opiates. It could be a heart attack when we're using cocaine or meth. It could be a lung cancer if we're smoking things. It varies from drug to drug, but it does increase the likeliness of a fatal outcome. So the 4 C's. I do want to kind of go to the next slide, but I'm going to leave it here for you guys. But I'm going to go over some other information to really understand the 4 C's. And that is what's going on in the brain when we introduce drugs. So as I said in one of the earlier slides, the reason people use drugs is to address a need. That need could be in high school to fit in. The person might not feel a lot of confidence in themselves or something of that sort. Typically, people who are using drugs and alcohol have a low standard for who they're friends with. If you're willing to use and get high and drink and have fun with them, they're willing to accept you. So I've seen so many people over the years begin using to fit in, or maybe it's because there's a mental illness going on and they have anxiety and they're using alcohol to alleviate some of that anxiety. Whatever the reason or that need that needs to be met is, they're using the drug to meet that need. However, that use starts to become reinforced. Okay, so when we look at positive and negative reinforcement, we know that anytime there's a reward, it encourages that behavior to continue. And so drugs and alcohol tend to give very large amounts of dopamine to the brain. Dopamine is a neurotransmitter that makes us feel good. Okay, so whenever we're getting those large amounts of dopamine, that behavior is going to be reinforced. So if the person uses initially to meet that need, but then that behavior begins to get reinforced through the dopamine, okay? Now, when we start to see changes in the brain, what's going to happen is we have 2 parts of the brain that's really affected. We have the prefrontal cortex, which is the part of the brain that's rational. It's going to think about consequences, things of that sort. It helps you stop and say, wait a minute, there's consequences to what I'm about to do. And then we have the limbic system, which is regulated by dopamine. It helps regulate life-sustaining behavior like drinking water or eating food or procreating or anything really to motivate us to get out of bed, to live our lives and get the things that we need to get done. This part of the brain gets hijacked, right? When we start to see those high levels of dopamine through the drugs and alcohol, it's almost like a computer virus, right? We have a computer and that computer operates on code. When we introduce a virus, that code becomes corrupted. When that code becomes corrupted, that computer doesn't know how to operate as it was intended anymore. The similar thing happens in our brains when we start to introduce drugs and alcohol on a regular basis. Because of those high levels of dopamine, that system gets a little bit corrupted. And so what happens is we don't necessarily get the dopamine that we should be getting from life-sustaining behavior like food and water and playing with our kids and procreating and having a good time and getting social interactions and intimacy and things of that sort that would normally give us dopamine. The brain reserves that for the substance use, okay? So we start to see things like cravings, which mimics the physical needs like hunger and thirst because it's actually corrupted the part of the brain that regulates things like hunger and thirst. We start to see compulsions, irresistible urges, or uncontrollable desire to find substance use because, again, this part of the brain is been corrupted. There's no consideration for the consequences because we're not getting dopamine from other behavior the way we used to. We're only getting it from the drug or alcohol. So the consequences really don't matter that much. And then obviously we're going to see a lack of control and restraint with the behavior afterwards. All right. So as I already told you guys, the limbic system is that pleasure system that works off of the dopamine. That part of the brain kind of gets messed up. It doesn't really operate normally once substance use disorder is taking place. And then because the prefrontal cortex helps regulate that behavior, it helps you think about the consequences. If we're using drugs prior to the age of 25, this isn't even fully developed, and those are really having an impact on the development of that prefrontal cortex, so we can see pretty long-lasting effects. All right, changes in the brain. I pretty much covered this, but I'll make sure. The brain uses neurotransmitters such as dopamine to regulate behavior essential for life. The brain changes with continued substance use, okay? Dopamine that is typically released with any pleasurable behavior will progressively become reserved for substance use and addictive behavior. And the person experiencing SUD will prioritize the substance use because it's the only behavior that produces pleasure in the brain. All right, good news, good news. These symptoms here on the side are what we call PAWS. They're post-acute withdrawal symptoms. Depression, anxiety, irritability, impaired concentration, poor impulse control, fatigue, insomnia, mood swings, foggy thinking, cravings, lack of motivation, lack of interest, increased sensitivity, poor memory, substance-related dreams. These are all things somebody's going to go through when they stop using drugs or alcohol. They're going to experience these symptoms, and they can experience these symptoms for up to 2 years as the body and the brain begins to heal. But these symptoms will relieve, and the brain will start to function as intended again if you give it enough time. That's the good news. With enough time, we should start to see a lot of the changes that were taking place with substance abuse start to normalize. But it's something that we do have to be patient with that person and support them, give them services along that way. Because as you can see with all of these things that they're going through here on the side, recovery is going to be difficult. Managing recovery is going to be difficult. Managing stressors and life and everything. Right, that's why we have things like peer recovery coaches to help them navigate these things, because it can be a bit overwhelming if they don't have that support. All right, so the role in trauma. So trauma, it can be a major driver of substance use disorder, chronic medical problems, mental health problems, physical illnesses, and early death. And we know this because of the ACEs study that was done in the 90s. I'm not going to go into that too much because I think you guys probably know a bit about that. But if you don't, a good place to start, there's a TED Talk by Dr. Nadine Burke on YouTube. I think it's a great introduction to the ACEs study. But in a nutshell, it basically says the more trauma that we have, the more likely we're going to see things like substance use disorder, chronic medical problems, and physical illnesses. So there's a pretty clear correlation there. How are we doing on questions? Anything?
No questions yet.
Good. Dr. Nadine Burke. Did you get that, Sarah? I put it in the chat for you guys. All right, SUD risk factors. Okay, risk factors are factors that increase the likeliness of substance use disorder. These things can be things like family history of SUD. Okay, if somebody has a family member who is struggling with SUD, this becomes a clear risk factor for them later on in life. And one reason I actually want to point out for this can be attributed to ACEs, because we know with the ACEs, there's like 10 of them. That's things like poverty, things like having a parent who has an SUD, having a parent who's absent, having a violent environment, being abused, things of that sort. And one thing that I found through my experiences in working in treatment is that if somebody has that risk factor of having a parent with an SUD, that tends to be attractive to the other risk factors. It tends to be poverty because they're prioritizing their money toward drugs over things that the house needs. There tends to be more abuse, more likeliness of abuse. That's not to say that somebody is abusing their children necessarily because they're using substances, but there tends to be other characters in the house who might be using the drugs with the parents, who might be abusive. There might be more violence in the house because people are going through withdrawals. So just having that one ACE tends to bring on all the other ACEs. So it's a pretty serious risk factor. Substance use at a young age. It's important to remember that again, this prefrontal cortex is still developing until that person's 25. The limbic system is fully developed in childhood, but when they're using drugs and alcohol in the teenage years, this really affects the development of the prefrontal cortex. And studies show that most substance use disorders that take place after the age of 30 started before the age of 30, like a high percent, like in the high 90 percentile, because the brain is still developing. Where if somebody has a fully functioning and developed brain, they might go and have a drink with coworkers after work, in our adulthood, and be less likely to develop a substance use disorder from that. Where somebody who's using in a younger age, when the brain is still developing, that use becomes a lot riskier for them. Adverse childhood experiences, those are those ACEs. Trauma and ACEs go hand in hand. ACEs are really just identifying different traumas that can take place in that child's life. Mental health disorders obviously can be self-medicated, and so that leaves a person vulnerable to a substance use disorder. And then peer pressure, right? We're all vulnerable to peer pressure, and whether we like to admit it or not, it does make things it's hard to resist that. It's hard to stand out. It's hard to say no. It's hard to be oppositional to the people around you. So when you get that pressure, a lot of times you just go along with it. Good news to this is we have protective factors. These are factors that build supports in a person's life to help promote resilience over risk factors. So resilience is the ability to overcome that adversity, the things that really make it more likely for you to become somebody who suffers from substance use disorder. When we build these factors in, what we're doing is we're changing your experiences. So if you guys know about cognitive behavioral therapy, our experiences form our core beliefs, right? And so this becomes kind of the subconscious, right? The subconscious that is influencing our conscious thoughts on a daily basis. When we provide protective factors, we're changing those experiences. So therefore, we're changing the core beliefs. So for instance, somebody who's in poverty, who hasn't had their needs met, might develop a belief that they got to do what they got to do, right? And so they might be more likely to steal or to take things because nobody's ever provided for them. They do what they need to do to provide for themselves. Whereas if we can put concrete supports in that person's life, things like food stamps or food banks, or assistance or school supplies with backpack drives and things of that sort, that child has their needs met. And so instead, they're going to develop a different set of core beliefs. They're going to learn to trust their environment, to ask for help, to seek out resources because their needs have been met. We've essentially changed their experiences, which is going to change their whole belief system. Other protective factors is family involvement and support. Whether that, if it's not the parent, is it the grandparent, aunts and uncles? What kind of support systems are available to that child? Emotional control. This can be established through therapy and things of that sort. Community engagement. Are there community centers? Are they able to engage with sports? Um, any type of community involvement is going to build other trusted adults and positive influences in their life. Peer support. So if we can get them involved in sports and things like that, they're going to establish peer groups. They're going to feel some sense of community, some sense of belonging. And so when we were talking about why do people use drugs, I said it's to meet a need. And sometimes that need is to fill in. If we're building peer supports, they're already fitting in somewhere. They already have that identity. And so the substance use is going to be a little bit less likely. Concrete supports, those are those having tangible needs met, like food, the things we need. Spirituality can be a protective factor. This tends to go hand in hand with community and early prevention efforts. So giving education, going out to the schools, talking to the kids, giving them the information. They're young people, and they really, at the end of the day, they're going to be making these decisions. So giving them enough information to make responsible decisions is important. All right. So building protective factors. These are just things that we can do to build those individual protective factors. And I really kind of went over that already. Before I transition over to stigma, how are we doing on questions? I believe you guys will be receiving these slides. Is that correct, Christy?
Yeah, as long as you're okay, we can send the slides out.
Okay. Carrie, are we talking about Dr. Nadine Burke? Yes, okay, good. All right, nobody else has a question. I'm going to move on to stigma. Okay, so stigma, it's a mark of disgrace associated with a particular circumstance, quality, or person. So in this instance, that stigma, that the mark of disgrace is that substance use disorder. That's what we're talking about. Stigma can be experienced in the public, driven by stereotypes of people with SUD, such as addiction is a choice or it's a moral failing. As I just kind of talked about the changes in the brain, we understand that the choice really is the first time we use. The more we're using, the more we're seeing changes in the brain, and that really becomes less of a choice for that person because the brain and the body is really working against them. So this one, the more we can educate, I think the more we can see that one kind of go away. Self-stigma. This one is really, really important, and it's probably the one that I'm going to focus on the most. It's the internalization of negative stereotypes about people with SUD. So self-stigma is so important when we talk about recovery, because really recovery, the foundation of recovery is hope. Okay. All recovery really needs to start with hope. Hope, the belief that my situation and my circumstances can change. Things can get better. Okay. This doesn't have to be what it is. There's some sort of belief that this situation can get better. That's the foundation of all really recovery. If we have no hope, the belief really is that this is who I am and this is the way it's going to be and things are going to end here. And so as you can see, there's really no room for change. And that's problematic. So we want to encourage hope as much as we can in a person in recovery, so they can build upon that. Because when we build upon hope, hope is almost like a snowball, right? You take that, oh my God, I apologize. You take that little bit of hope and right, like a snowball, you roll it and it adds hope into it and adds hope into it. So that person's hope in the beginning might be just to stay alive, right? But as that hope builds upon itself, that hope can now become something like, I might want to get into sobriety, or that hope might be that I want to get a job for the first time in years. That hope might be that, I want to reconnect with my family. But then as that gets added to it, and we can start to dream bigger and have more vision and more hope in our life for more things. And so you'll see that person really flourish in recovery once they have that foundation of hope, and we add, layer upon layer to it, and really see that hope grow. And the reason I bring that up with stigma is because I believe that stigma is the enemy of hope, right? If we can stigmatize somebody and make them think that that's just who they are, this is a choice, they're a failed person, that person's going to get stuck in that place, and really they have nothing to build upon. Okay. In the recovery community, we see stigma and pathway differences, right? So people in AA and NA might say that medicated assisted treatment is still using, right? But somebody who's really struggling with opiates, medicated assisted treatment might be the only alternative to death, right? We've seen those people who are using to the point where they're on the verge of death. And if we don't give some type of intervention, there's no hope. I got to go back to hope. But if we can get them on medicated assisted treatment, we're able to at least stabilize them to where we know that they have a life to live. There's hope for that other change down the line if they choose, or they may choose to stay on medicated assisted treatment for the rest of their life. And if that works for them, who are we to question that? Okay. And then with clinical providers, if we've ever been to the doctor and the doctor wasn't listening to us, if we've ever been, had a police interaction and you felt like there was some sort of judgment, this is the type of stigma we're seeing sometimes in the community with people who are using substance use disorders. Then I can speak not from a substance use disorder point, but I'll tell a quick story about me. I recently got diagnosed with celiac disease, and it's just something I've been suffering with for 20 years. And I remember going to the doctor in my early 20s with some symptoms, and the doctor's just kind of blowing me up because it was a new disease, or at least something of a fad at the time. And so they kind of brushed me off, and I was a little bit stigmatized by it. And what I did was I suffered with it for 20 years and didn't seek treatment because of the way they treated me when I sought help. That's really important, because if we're delivering that same type of treatment for somebody who's seeking help for a substance use disorder, they're going to turn away from the services that we're offering because of the way we made them feel in that moment. All right. So how does stigma affect a person with SUD? It's going to destroy self-esteem. Again, making them believe that this is just who they are. The situation can't change. It can be damaging to their relationships because maybe their family is really losing hope and that their situation can change. It can inhibit access to services. Like I said, maybe they're not seeking them out, or maybe the services aren't suitable because of the providers having stigma. And it can discourage harm reduction. So things like medicated assisted treatment, maybe they're not seeking that because the AA community is pressuring them. I would hate for that person to OD and die because they're not using these services, or maybe they're not using a syringe program because of that stigma, right? But that person, these harm reduction programs can be so effective at minimizing the risk while that person's using. Again, when we build on that hope, their vision of recovery is going to change. So if that hope is that I'm using right now, and I'm going to provide you clean use supplies, so that way you're not getting diseases, so you're not, losing limbs, so you're not having all of these long-term consequences to your use. I'm developing a relationship with you, so you know where to go when you do want more. If that person does, change their desires and their vision of what their recovery can be, they're going to have a lot less long-term consequences because of that syringe program, because of those safe use supplies. And really, that's going to promote an even more successful recovery later down the line, because they don't have those stressors that make them want to go back and use. All right. So person first language. We want to really emphasize that this is a person. Right? Everybody wants to feel like a person. Everybody wants a little bit of dignity and respect and humanity. And so when we're dealing with people suffering from SUD, we want to emphasize their personhood, give them that dignity as a person, so we can really build upon that. If we just look at them as an addict or a junkie or something of that sort, that's dehumanizing, and it's really going to, again, destroy any sense of hope and really make that person believe that that's just who they are, and things aren't going to change. Ways we can do that, instead of words like addict, we're going to say a person with a substance use disorder. Instead of something like dirty, this is a person who's currently using. Somebody who's clean is somebody in recovery. Okay, somebody maintaining sobriety. 61% of patients with SUD received at least one case note that included stigmatizing language, right? So if this one case note, that's one documented note, and that's right when we're the most careful about what we say, when we're documenting case notes. Imagine how much stigmatizing language was really used with that person when talking with that person and dealing with that person, or even talking about that person. You know, a lot of times we don't realize that people are around us listening, and maybe somebody heard us talking about that person. And as we know, in these environments, that type of behavior tends to spread. So maybe you have two providers talking, and then you know, that could really affect the way your coworkers look at that person, and or the people that they're treating. All right, down to the next section. How are we doing on questions, guys?
No questions right now.
Okay. All right, recovery. So recovery is the process of improved physical, psychological, and social well-being and health after having suffered from a substance use disorder related condition. So this just means that things are getting better, right? When we talk about multiple pathways to recovery, really this could look different from person to person. One person's recovery might be sobriety. Another person's recovery might be using safe supplies, right? And harm reduction, because you know, they're making some effort. Remember, if they're just using harm reduction supplies, there's some level of hope. If there wasn't a level of hope, they wouldn't be doing anything. They would just be using to die, right? But they're actually taking the effort to meet up with a harm reduction team to get safe use supplies. That they have some desire for things to be better than whether that desire is just to stay alive, right? That's some level of hope that we can build upon. Multiple pathways of recovery. This can be clinical, like detox or inpatient treatment, outpatient, individual family counseling. This can be medicated assisted treatment. It can be harm reduction, as we've talked about, sober living, communities, and support group meetings like NAAA, Dharma, Celebrate Recovery. Remember, it's so important. There's so many beyond NA and AA now. The person try different ones to see what really resonates the most with them. And peer recovery coaches, sponsors, life coaches. And then there's so many beyond this, like spirituality and things of that sort. But with multiple pathways, remember, it's almost like a la carte. That person is going to pick and choose different pathways to really address them, their trauma, their history, their experiences in life, and the things that they've gone through. And the more that they can work a plan that really addresses them and their needs, the more positive outcome they're going to have. Medicated assisted treatment is the use of medication in combination with behavioral therapies for treatment of substance use disorder. It's FDA approved medications that have been prescribed by a physician. It can be effective with alcohol and opiate use disorders. can be injectable, liquid medications, pills, tablets, patches. And it can be extremely stigmatized by society and recovery communities. But again, as you guys are seeing in the community, when we talk about opiate use disorder, I mean, I've seen it so severe that the only alternative to death really is medicated assisted treatment. That's not to say that, you know, that's going to be where they're going to be for the rest of their life. And it may be, and it is, that's fine. But it's a start. If that person dies, there is no hope, right? There's nothing to work upon. So if we can stabilize them and keep them alive, that's at least a starting point. And taking MAT for SUD is no different than taking medications for health-related conditions, right? And then on the side here, we have some different forms of medicated assisted treatment. MAT is trading one addiction for another. That's a myth, right? It's a medicated medication treatment. It's backed by a doctor. We're going to get some clinical therapy and support with the MAT. It may be a short-term solution. It may be a long-term solution, but it is not trading one addiction for another. It's definitely a different ballgame. If you use MAT, you're not in recovery, right? We're not in the business of defining somebody's recovery, right? When somebody has multiple pathways, they're going to define their recovery. They're going to really work a plan to address them, and their recovery might not look different. It might not look the same a year into recovery and 5 years into recovery and 10 years of recovery. And that's why we really want to support them where they're at and what their vision of recovery looks like. And so again, that may be something that they build upon, or they may find that in the initial plan that they work, that they're living a good quality of life. Things are better. They're not having legal problems, and that might be a great plan for them. And who are we to question that, right? Most insurances do cover medicated assisted treatment, and when the medications are taken daily as prescribed, there shouldn't be a risk of, you know, a high risk of addiction. It's important with any prescription medication that we're taking it as prescribed, that we're making regular doctor's visits, we're working with our medical team, right? When we do these things, we're limiting the risk of use at that point. Harm reduction. It's a set of practical strategies. How are we doing on time, guys? Okay. And ideas aimed at reducing negative consequences associated with drug use. Okay. This can be things like HIV and Hep C, right? We're going to use needle exchanges and testing to help limit some of that risk. It could be something like medicated assisted treatment to really help support somebody who's struggling with opiates. It could be getting medical treatment on wounds and care, so that way that person doesn't have a lost limb or something like that, that even if they do find themselves in sobriety, right, now they have this long-term consequence because of that use. If we can limit some of that use or some of those consequences, we're going to see a more positive long-term outcome. All right, so what is harm reduction? It's a realistic, pragmatic, humane, successful approach to addressing issues of substance use. We're recognizing that abstinence may be neither a realistic or desirable goal for some people who use drugs. It was introduced in the US in 1985 following the AIDS epidemic, and it can be extremely stigmatized by society and the recovery community. Harm reduction programs can allow access to Narcan, safe syringes, safe disposal boxes, sterile use supplies, fentanyl and xylazine test kits, condoms, HIV and HCV testing, hygiene and clothing, basic healthcare services, medicated assisted treatment, peer recovery services, and access to transportation and treatment. So as you see here, right, when we're providing harm reduction programs, we're really just providing services to these people. And we know that when people get involved with services, they're more likely to use other services. And so it can really be an entry point into services for them. And so it really is beneficial to long-term recovery. People are 5 times more likely to seek treatment services if they're involved in some kind of harm reduction program. I know with our harm reduction program alone, right, where we send a van out into the community, we're meeting with these people on a weekly basis. If they decide that they want treatment, they already have our number. They already are right at our door. They're so connected with us that it's really effortless, right, to transition from harm reduction services to other services because we've already established that relationship with that person. Harm reduction myths. Harm reduction programs enable drug use. And so I hate to be crass, but like one type of harm reduction is condoms, right? I've never had sex because I had a condom in my pocket, right? But if you choose to have sex, it's better to have that harm reduction tool at your disposal, right? To limit some of the risk of stuff like that. People are not going to use because we provide supplies. It's just making use safer. Harm reduction is only for people who use drugs. And as I just said, condoms are a form of harm reduction. Seatbelts are a form of harm reduction. So we use harm reduction in the community on a regular basis. Harm reduction services make neighborhoods less safe. That's just not true, right? And it can improve safety when we're providing disposal kits, right? We're eliminating some of the used needles in the ground and just stuff like that. Yes, people may come to different communities to get those services, but they're going to return back to their community as well. Giving out syringes will cause more needle litter. That's, again, not true. These people are going to use the needles anyway. We're providing them to safe disposal kits and things of that sort to help reduce that litter. So stages of change. Most people on here should be pretty aware of stages of change. So this can apply to really any change that we want to make. So again, recovery may look different from person to person, but pre-contemplation is really that lack of hope or lack of awareness that there's a problem, right? This is just who I am. This is my life. Things are what they are, right? But then that person moves into contemplation when they realize something's wrong or something needs to change. This is not working for me. Whether it be, losses of jobs or losses of loved ones or isolation or illness, something's wrong, right? And I need to make some changes in my life. Preparation is really making a plan on what kind of changes I want to make, what kind of things I want to do differently to get a different outcome. I move into action when I start to apply those changes to my life. And then if I'm seeing the desired outcome, I'm in the maintenance stage. And if I go back, I'm back in, I'm in the relapse phase. When we go relapse, we can come back at any point in this plan. But usually I would say you're going to go back into the preparation stage. If you've relapsed, you need to rework your plan. Something didn't work. I need to develop a new plan to address me in these different ways until, I get the desired outcome and I find myself back in the maintenance phase. But I want to remind everybody, the same plan that gets you in the maintenance phase is not going to be the same plan that keeps you there, right? Because your plan has to address you. And as we grow and as we change, I become a different person along the way, right? Things happen in life that my old plan may not have addressed, like grief, right? For instance, somebody in recovery, their initial plan might not address grief unless grief was an initial trigger to the initial use. it probably is going to address grief. But if it's not, they're not going to really address grief, right? They get into the maintenance place, somebody passes away, they're going to really need to rework their plan to make sure it addresses grief so they continue to see that desired outcome. Meeting people where they're at. We're going to bridge the gap between our own expectations and where that person is coming from. Again, this person really has to work a plan that addresses them, their experiences, their trauma, their culture, their community, their values. And we can't really impose our values and beliefs and culture and things on them. And so we meet them where they are. We support the recovery plan that they want to work. And then that plan may start to look more like what we might desire for them somewhere down the line, as they build upon that and their hope and their vision for their life begins to expand. But we need to start where they're at, and really support them in that space, because really that's all we can do is give hope, right? That person needs to do the work. They need to make decisions because they have to live with those decisions, not us. All right. So this is kind of just a little breakdown of our programs here at FAN. We have Harmless, which is our harm reduction team that takes a van out into the community. A medical team goes out with them. We provide safe use supplies, needles, disposal kits, testing, things of that sort. We have a quick response team that goes out into the community when we get referrals from the police department, connects with those people, seeing what kind of services they may be interested in, or just giving them some support for whatever's going on in their life. Redirect team is our diversion program. So we provide case management support when somebody is starting to get involvement in the criminal justice system. Hope Not Handcuffs is our hope line, and our partnership with the police departments to get people into inpatient treatment or to connect them with services throughout the state of Michigan. Navigate is our peer recovery and family coaching program. Peer recovery coaching is statewide. Family recovery coaching is for family members of people who are struggling with substance use disorder. We provide a coach who is a family member who's dealt with somebody who had somebody in their life who had substance use disorder, who's going to work with that person for 12 sessions. I think it's a really important program. We do sober living scholarships across the state of Michigan. If you know somebody who's in need of sober living, we may be able to assist. Stronger Together is a support group for family members of people struggling with substance use disorder. We hold FAN forums monthly in Macomb County and through some of our other chapters throughout the state. And then Rescue is our naloxone program. We provide naloxone education distribution boxes throughout the state of Michigan. And then not on here is our community education. That's the team that I'm part of. We do provide community education to really anybody in the community that would like to host us. We'd be glad to give something similar to this or really tailor a presentation for your community or the audience that is seeking some education on substance use disorder. I will got about 10 minutes that I can open it up to questions. Are you with me, Christy?
Yeah, we do have a question here from Chris. He says, going back to the language of dehumanizing, such as addict compared to a person actively using, would that include self-talk, continually referring to oneself with that language? And if so, how can we steer away from such negative self-talk?
I think that it definitely could be, right? Because addict is describing the behavior. Person with substance use disorder is emphasizing the person struggling with the behavior. Chris, I'm going to tell you a quick story about me quitting smoking. And I know cigarettes are not, and nicotine is not the same ballgame as something like crack and opiates, but I think it's important, right? And I remember that I was quitting for New Year's, and this was about midnight, and I was actually at a church service. And I remember talking to one of the deacons about that I was going to quit smoking for New Year's. And I had to drive back from Mount Clemens to Ypsilanti with my friend, and she was a smoker. And I'm like, she's going to smoke in the car and the whole way. And I'm going to, so I'm just going to quit in the morning. He said, you quit. And I said, and I tried to, rationalize with him. And all he said to me was, I quit. And so when I got in the car, and she's lit up her cigarette, and I'm smelling it, and I'm desiring it, and I'm craving it. I kept telling myself that looks good, that smells good, and I want it, but I quit, right? And I had to do that to myself for months. Every time I had that craving, I talked back to that craving, and I reminded it that I no longer smoked. Because if the only messaging we're hearing is the craving, the desire, and this, we're going to start to believe that, right? Sometimes we have to give an alternative message to that. And I think that's important, right? If we've ever been in an abusive relationship and somebody talked down on us and called us stupid and called us this every day, if that's the only thing we hear about ourselves, we start to believe it, right? So there has to be some alternative narrative. So I would be careful with calling myself an addict every day, because if I do that for long enough, I'm really going to believe that. Does that answer your question?
There's also a question in here, and she said this may be an email. Is there any potential for Lapeer Fan to become a chapter once again? It seemed that during COVID it fell apart or had to close. Really good organization, and our specialty courts in my county I work with at one point required participants to attend fan meetings. She did include her email if you
Yes.
are able to contact her about that.
I will definitely email you and get you into contact with our chapter development person. And then they can really assist you with that discussion on how we can get that going again.
And then Nancy asked, are these services available throughout Michigan? Can we find these on your website?
Repeat that.
She wants to know if your services are available throughout Michigan and if they can be found on your website.
Yes, we do provide all services throughout the state of Michigan. Sometimes logistics are going to be an issue, right? So maybe we don't have a local fan chapter, maybe we don't have somebody in that area. So peer recovery coach might look differently. It might be something that's virtual, but it's really important if the infrastructure that is developed in that community is working, right? And you have all of these entities, you have these peer recovery coaches, use those entities, that's fine. But do not let that person fall through the cracks, right? If they're not able to service or provide adequate support from, we definitely want to get them connected with us so we can give them some support, and get them connected as much as we possibly can. And then there's other areas where we might have such a presence that we can provide equivalent levels of support and care for that community. But yes, if you go on our website, all of our different programs are broken down. But I would always just recommend, if somebody's looking for services, call the Hope Line. They're open early in the morning till 10 o'clock at night. They take phone calls, and they will really work with somebody for as long as it takes to either connect them with our services or find them suitable services in their community.
Okay, Chris did also comment, and he said, how do we encourage others to speak positively about themselves?
Right, speaking positively about ourselves, right? As I was just telling that stories always help, right? If we can share a story and help them relate to the power of positivity, the power of encouragement, the power of speaking to ourselves, that's really going to impact them. And so if you have a story, I would definitely share that story with them. But I know people who are in recovery who get in front of that mirror and speak to themselves every day with that positivity. It's definitely essential that you hear that messaging, right? Because that negative self-talk might be down there, you know, in the subconscious. And if we don't give an alternative narrative, we will begin to believe that if that's the only thing we're hearing. So it's essential that we really give that alternative narrative, because eventually you will believe that too, right? You will believe whatever positive reinforcement that you're giving unto yourself, and given enough time.
And Jamie is asking, what is the phone number for the Hope Line?
Why is it not on there? Give me 1 second. I'm gonna put it in the chat. This is a Hope Line, and I am Carlos at faceaddictionnow.org. And just so I believe this audience is a lot of providers throughout the state. I've been giving education at recovery homes, nursing homes. A lot of you guys have resources and are doing prevention education. Please continue to do that. But if there's a sector of your community and you need that support, you know, we're grant funded for the state of Michigan, and we'd be glad to really assist your community and assist in the work and help support the infrastructure that you guys have established throughout the state.
All right, there's a lot of thank yous coming through. I don't see any other questions.
Well, I have access to the chat to,
Okay.
if we close it, do I lose access to the chat?
Yes.
Okay, let me just review real quick and make sure. Was there anything, you've been moderating the chat the whole time, right? There's nothing that I missed that I need?
No, just maybe the email, or I'm trying to go back now to if you got the email for the individual that had questions about.
Yeah, I did provide my email on here.
Okay.
I provided the Hope Line phone number. Okay.
All right.
All right. Well, we're at 10 o'clock. So if you don't have anything else for me, Christine, I will wrap it up.
All right. I'm going to do a quick, unless you have anything else to say, I'm just going to do a quick wrap up.
Okay, go ahead.
All right. Well, we want to just thank you for your time, Carlos. Thank you for, you know, stepping in with Maddie at the last minute for Maddie. We really appreciate it. It was a lot of good information. Thank you all for attending the session today. We hope you found the information shared valuable. Today's presentation is one of many webinars scheduled throughout the month of September. To see information and register for additional sessions, please visit our website at www.sccmh.org. Before we wrap up, we would greatly appreciate your feedback on today. A survey will pop up on your screen shortly, and we kindly ask that you take a few moments to complete it. Your input is crucial in helping us improve future events and better meet your needs. For those of you that are requesting professional credits, please allow 2 to 3 weeks after the summit has concluded, and your certificate will be emailed to you. Thanks again for joining us today. We look forward to seeing you next time. Have a great day.